Okay, hello friends, welcome back to my channel Medicine 101. Today we'll talk about cardiac arrhythmia. Okay, it's one of the most important topic regarding the cardiology. Okay, so before studying the topic, let's know it's the pathological arrhythmia. So definitely there should be normal rhythm. Okay, so whatever the things we can get in terms of the cardiac normal rhythm. Okay, so let's write it over here. Basically, if we see that whenever we're talking in terms of the cardiac normal rhythm, basically what do we know about it? That from where? From basically the AC node or the cardiac impulse that should be originated, okay? And after that, after the originations from the AC node, it will come to the AV node. Then what? It will go to the bundle of phase. Then it will go to the fibers in the ventricular myocardial cells that will supply over there. And another thing that whenever the impulse is coming, that should have the normal velocity. Basically, we can say in terms of the AC node, there should be the moderate velocity. Whenever it will come to the AV node, there what the velocity will be little bit decreased. And in terms of if we see in terms of the bundle of fibers, the Purkinje fibers, where we will get the velocity maximum over there. Okay, so let's write it over a normal rhythm. So normal cardiac rhythm. Whatever the thing we'll get in these cases, another cardiac normal rhythm over here. Now first thing first, let's write it over here that okay, in this case you have to know that the heart rate that should lie in between 60 to 100 beats per minute. 60 to 100 beats per minute, okay? We'll get in the first thing. The second thing is over here that I have already said that what the cardiac impulse that should be originated from the AC node. If we see instead of that, if we see the originations of the cardiac impulse from the other place rather than the AC node, then it will be regarded as cardiac arrhythmia. Okay, so we can write it over here that cardiac impulse should be originated from AC node. Okay. Now if we the third thing, whenever the cardiac impulse is originated, it's okay, good. Now the cardiac impulse that should propagate it under the what? Normal conduction pathway. Let's write it over here that cardiac impulse should go through normal conduction pathway. Okay. Number fourth, that it will go under the normal velocity. The cardiac impulse that should have the normal velocity through the normal conduction pathway. Now let's write it over here. Then I'm going to explain. Okay, so we can write it over here. The cardiac impulse should have normal velocity whenever it is propagating through the normal conduction pathway. Now let's show you over here that what do you mean by third point? I mean cardiac impulse should go through the normal conduction pathway. First things, let's write it over here. I'm just assuming it's a heart over here, okay? Now the fibrous annulus over here. Let's anyway, now see. The first thing I have said it over here that the beat should be in between 60 to 100 per minute. Okay, so I'll just explain a little bit later this one. The second thing, cardiac impulse should be originated from the AC node. So if I just assume this is the right atrium, this is the right ventricle, this is the left atrium, this is the left ventricle, then it should be originated from the AC node. For example, I'm just taking the AC node over here. Then after that, what it should go through the normal conduction pathway. Normal conduction pathway, that means what? At first we will see that originated from what? AC node. After that it will go to the Johnson node or the AV node. After that it will go where? Within the bundle of phase. Then it will go where? Within the Purkinje fiber. Then the myocardial cells. Okay. And What about the velocity? What about the velocity? Whenever we are seeing in terms of the SA node, here the velocity around 1 meter per second. Within the AB node, the velocity that should be less. And what about these things in the bundle of or in the Purkinje fibers? That should be the velocity will be maximum. Or we can say the very first bundle of is or the Purkinje fiber, subsequently will get. So here we will get the velocity that will be more. Okay. Now we can consider this will be the moderate velocity. This will be the less, and this will be the what, the first. The velocity we will see there will be that will be more than the AC node as well as more than the AB node also. Okay. Now I have already said these things. Now I will just explain this one, this point. The cardiac heart rate that should be what, in between 60 to 100 beats per minute. Okay, for that thing, let's erase some part from here. Then I'm gonna explain this thing. Now, see, I'm just considering. Let's consider this part. I have said it should be in between 60 to 100. Okay, so I'm just taking this as 60 beat per minute. It's a 60 beat per minute, and I'm considering this the 100 beat per minute. Now, whenever we'll get the beat in between these two, whenever it will lie in between these two, that will be regarded as normal. Okay. Now, whenever we are getting, for example, from 100 to we are getting, let's write it over here, 150. Let's make it straight. Whenever we are getting 100 to 150 beats per minute, in between, okay, from 100 to 150 beats per minute, this will be regarded as simple tachyarrhythmia, because we know that whenever heart rate that will get increased, that is known as what, tachyarrhythmia. Whenever it will go down, then the normal level, I mean less than the 60 beats per minute, we have to quantitate it. We have to just consider it as the bradyarrhythmia. Whenever the heart rate that will go down, then the 60 beats per minute, we have to consider this one as the bradyarrhythmia, and more than 100 beats per minute, it will be regarded as tachyarrhythmia. So the first thing we'll get over here, that will be regarded as the simple tachyarrhythmia. Whenever it will lie in between 100 beats per minute to 150 beats per minute, so it will be regarded as simple tachyarrhythmia. Okay. For example, if you get the beats from 150 to 250 beats per minute over here, for example, it's a 250 beats per minute. Whenever we get in between 150 to 250 beats per minute, actually this time of the beat will get suddenly, it will get sudden appear, and it will be what, disappear suddenly. Okay, so it will come sudden appear. Again it will suddenly disappear. Now this type of thing that is known as paroxysmal tachyarrhythmia. This is known as paroxysmal tachyarrhythmia. Okay, and if we get the heart rate in between 250 to 350 beats per minute, 250 to 300 beats per minute, you have to consider this thing as what, flutter. This thing is known as flutter. Okay, and if we get the most dangerous one over here right now, more than 350, if we get more than 350, this thing is known as fibrillation. This thing is known as fibrillations. That means more than 300 beats per minute, if we get, this thing will be regarded as fibrillations. Now fibrillation we can see in terms of the ventricle, in terms of the atrium. So we can get the atrial fibrillations, we can get the ventricular fibrillations. So let's write it over here. We can get over here the atrial fibrillation, or we can get the ventricular fibrillation. Okay, this is the thing. Now we'll talk about in terms of the bradyarrhythmia. Now we got it over here. Now for example, if we get the beats in between 60 to 40 beats per minute, okay, if we get the heart rate in between 60 to 40 beats per minute, this thing will be regarded as moderate. moderate bradyarrhythmia. If we get, okay, let's write it over here, 20 beats per minute. Okay, let's use this one for it. So yes, it will be the mild one. It will be mild bradyarrhythmia. If you get in between 40 to 20 beats per minute, this thing will be regarded as moderate bradyarrhythmia. And if you get less than 20, in this case, if you get less than 20, this thing will be regarded as severe bradyarrhythmia. Severe bradyarrhythmia. Okay. Now these are the things as far as the heart rate is concerned. If we get more than 100, whatever the changes we'll get in these cases. If we get less than 60, whatever the changes we'll get in these cases. Okay. Now we'll talk about the different aspects. Now, at first we'll talk about the originations. If we get the different kind of the origination or the original problems, I mean in terms of the source of the cardiac impulse, whatever the thing we can get. Now for that thing, let's draw a little bit of the heart from it. Then I think it will be easier for you to understand the whole concepts. Okay. Now see, I'm just considering. Okay, let's do it over here. Okay. The fibrous annulus. We are getting in this way. Can you try to understand from this figure? Now see, if we see that the source of origination is of, we know the AC node, but if we get any kind of the problem in the AC node, at the level of AC node, for what if we just see the development of the rhythms, I mean arrhythmia, this is known as sinus arrhythmia. This is known as sinus arrhythmia. Now if we get any kind of the problem from, for example, from the atrium, if we get any kind of the problem for what we are getting, if we get any kind of the problem in the atrium for which we are getting the development of the arrhythmia, this thing will be known as what? This thing will be known as atrial arrhythmia. Okay. Now, for examples, we are getting any kind of the arrhythmia, any kind of the problem or development of the arrhythmia for the problem at the level of AV node, that is known as junctional node. So we can say it over here that for this thing we can write it over here that we get junctional arrhythmia. Or we can say another name for it, that is the AV nodal arrhythmia or nodal arrhythmia, simply we can say over here. A nodal arrhythmia. Okay. Now see, if we get any kind of level of the ventricle for which we are getting the development of the arrhythmia, this is simply known as ventricular arrhythmia. Ventricular arrhythmia. Now notice one thing. If we just consider these three, arrhythmia, I mean in terms of the acinodal arrhythmia, in terms of the atrial arrhythmia, in terms of the junctional arrhythmia or the nodal arrhythmia, these three things they are locating what? The superior of the what? Ventricles. So as a result, we can say that the acinodal arrhythmia plus the atrial arrhythmia plus the nodal arrhythmia, these things are the locations they are locating what? Above the what? Ventricles or superior to the ventricles. As a result, in another what we can supraventricular arrhythmia. These three things, after doing the combination of them, we can write it over here, the supraventricular arrhythmia. Supraventricular arrhythmia. Okay. Now we'll talk about the different kinds of the mechanisms. So there are basically the three types of the mechanisms for which we can see the development of the cardiac arrhythmia. Let's talk about them. Okay. So now we'll talk about the mechanisms. So let's write it over here. Okay. So we'll talk about right now in terms of the mechanisms. Now let's talk about the mechanisms. First thing first. So basically we'll get a triad for which we can see the difference of the reasons for developing the cardiac arrhythmia. The first thing over here, the second over here, third is over here. The first thing we can get it over here for increase the automaticity. Automaticity. Now what is automaticity? Automaticity means if we get any kind of the excitable tissue, that can go under the depolarization spontaneously. Okay, that can go under spontaneous depolarization. That will be known as what? Automaticity. That we see in case of what? SN node. So any excitable tissue undergo spontaneous depolarization. Spontaneous depolarization. The second thing we'll get over here, another reason for it, triggered automaticity. I will talk about these things at this point. Triggered automaticity. And the third thing we'll talk about re-entry or movement, circus movement. Okay, in this case, or re-entry or circus movement. Now we'll talk about one by one. First we'll talk about the automaticity. Okay, for that thing I have to take the SN nodes, the piece of SN node. Okay. Now I'm just taking a piece of SN node. Okay, for what I have to draw a little bit. The first thing, try to understand from here. Now see, if I just consider this the SN node over here, whatever thing we know in these cases, basically we know, okay, let's write it over here. This is the resting membrane potential. Okay. This is the threshold potential. Okay. Now as we know that definitely what within the SN node there are freely permeable sodium channels, right? We will get over here freely permeable sodium channels. So you will see there will be influx of the sodium within the SN node. Whenever the sodium will come within the cell, as a result we will see it will take the resting membrane potential. Okay, let's so with the red color, it will take the resting membrane potentials up to the what? Threshold potential. It will take the resting membrane potential up to the threshold potential because of the sodium influx. And whenever we will get over here, that it will just reach to the threshold potentials within the membrane, that is presence of what? Voltage sensitive calcium channel. So whenever it will just reach to the threshold potential, on that thing will get that voltage sensitive calcium channel that will be opened, and we will see influx of the influx of the calcium. We will get influx of the calcium. As a result, we will see what the depolarization of these things. I mean, in this way, we'll get what the depolarization. So this depolarizations, that is what that is by the what that is acted by the voltage sensitive calcium channel. Okay. So after that we will get whatever the thing. Whenever it will reach to the peak, after that we will see the opening of the potassium channel. We will get what the opening of the potassium channel. So whenever the potassium channel that will be opened, so potassium that will leak out. The potassium that will leak out. As a result, we will see after the depolarizations that will come back to the repolarizations. For example, just like this one. Okay. Again, we will see that again the sodium, sodium channel that will be open. Again, the sodium that will take the resting membrane potentials up to the threshold one. Again, the what we will see the opening of the voltage sensitive calcium channel. The calcium will go with there will be influx of the calcium within the SN node. And whenever the SN node, calcium that will be more, that will take the threshold potentials to the maximum peak. Then again the potassium channel that will be open. Again it will go under the repolarizations. Okay, let me show a little bit more. Now see from here again. The same thing we will get over here. It will take from here to the or resting membrane potentials to the threshold potential. Then again the calcium dependent depolarizations will see over here. Again the potassium channel that will be opened, and whenever it will be opened we will get the repolarization. You know these things, right? We will get the repolarizations. Now see, for whatever the regions, if we see that there is activations or overactions of the epinephrine or norepinephrine, epinephrine or norepinephrines, because we know that within the heart there is presence of what? Beta 1 adrenergic receptors. So whenever the overactions of the epinephrine and norepinephrine we will see over here, in these cases these things will be stimulated, and we know there is the what? Destimulatory receptors. Whenever it will be stimulated, it will just do phosphorylations, phosphorylation of calcium channel. We will see over here extra phosphorylated calcium channel. We will get over here extra phosphorylated calcium channel because of the what? Action of the epinephrine and norepinephrine. So in these cases we will see there will be too much load of calcium. We will see that too much load of calcium where? Within the SN node. Whenever we will get that too much calcium is coming within the what? SN node, definitely try to understand from here. Whenever the calcium is too much, definitely that the resting membrane potential that will go very soon where? That will go very soon to the threshold potential, and in these cases we will get what? Much more stronger depolarizations. After that the potassium channel that will be opened. After that it will come back to the normal repolarization, just like this. In the same way again we will see that for the what? Loading of the calcium ions were within the SN nodes, definitely again we will see that the resting membrane potential that will be raised to the threshold potential very soon. Then the normal, okay, what we see in the normal it will take time a little bit, okay, but here we will see the very rapid increase the resting membrane potential that will raise to the threshold potential. Again we will get, the more stronger depolarizations. Again we will get the, for the potassium channel opening we will get the repolarizations. In the same way again we will get this type of the thing. Go faster, again more stronger depolarizations, again we will get this type of the thing. Okay, so for the actions of the epinephrine, norepinephrine we are getting over here, that will take the resting membrane potentials to the threshold potential very soon, and it will just produce the stronger, depolarizations. After that opening of the potassium channel, that will lead to the depolarization. This is the first mechanisms that we can see in terms of the automaticity, in terms of the SN node. So for whatever the regions, if we see the actions or the overactions of the epinephrine, norepinephrine is increased over here, that will stimulate the beta 1 adrenergic receptors, and that will phosphorylate the what? That will phosphorylate the calcium channel. So we'll get over here the extra calcium channel. So phosphorylated extra calcium channels. As a result, we will see the influx of the calcium ions within the SN node, and that will lead to the threshold potentials, resting membrane potential to the threshold potential very soon, and after that it will do the depolarization. So this is the first mechanism in terms of the automaticity. Now we'll talk about in terms of the triggered automaticity. Okay. For that thing I have to do some part. Okay. Where can I place? The second thing, the second mechanism we can talk about over here, there is a triggered automaticity. Okay. The second mechanism, triggered automaticity. For this thing, I will take a piece of the ventricular cells, ventricular myocardial cells. For example, let's take it over here. Ventricular myocardial cells. Okay. Now, what do we do in these cases? In these cases, we will also get the resting membrane potential. In these cases, also we will get what? The threshold potentials. Okay, normally, what do we know in terms of the normal mechanisms? That this is induced by the what? Sodium. So sodium dependent we will get over here. That the sodium dependent. Okay, let's write it over here. First, we will see the influx of the sodium from the neighboring cells. The sodium that will come. Okay, and whenever the sodium will come to these cells, that will take the resting membrane potentials to the what? Threshold potentials. And see, whenever it will go to the, okay, let's write it over, resting membrane potential is the threshold potential, and whenever we will see this is just reach the threshold potential, onset of that we will see opening of the what? Voltage sensitive calcium channel. With the opening of the voltage sensitive calcium channel, there will be influx of the calcium where within the cell, myocardial cells over here, and it will take, we will see that what? Calcium dependent depolarizations. Okay, actually we will get just like this one. Now see, in these cases we are getting the calcium dependent depolarizations. Calcium dependent depolarizations. See, we are getting a plateau phase over here. Plateau phase. Why? In these cases there is no net change in the action, action potential. So the now see, in these positions in the plateau phase, whatever the thing will get over here, in these cases we will get that what? The calcium that will come in, but in along with that we will get the potassium that will start leaking outside. So in these cases, whatever the thing will get over here, try to understand the calcium that will come in, and along with that we will get the potassium that will go outside. So as a result, we will see there will be no net change, in the potentials. So we will get the plateau phase in this way. After that, we will see at a time the calcium channel that will stop working. That means there will be no influx of the calcium within the cells, but the potassium influx that will be continuing. So as a result, the potassium that will go outside of the cell. So whenever it will go outside of the cells, that will come under the repolarizations. Okay, that will come under the repolarization. In the same way, again we will get sodium dependent from the resting membrane potential to the threshold potential. Again it will reach to the maximum peak. Again we will get the plateau phase. Again we will get this type of thing over here. Okay. Now why did I mention the triggered automaticity? Triggered automaticity means for whatever the regions, if we get the membrane abnormalities, we will get that originations of new action potentials. For example, we are getting origination of new action potentials from here. Originations from the new action potentials, and that is known as early after depolarizations. This thing is known as what? Early after depolarization. Early after depolarizations. Okay. So in these cases, we can get some ischemic injury within the cell. What are the regions? Let's write it over here. We can get the ischemic injury. Okay. We can get in terms of the infarctions. Okay, let's write it over here, the regions. If we get the overactions of catecholamine, we can get, these are the regions. Here we will get, there will be the origination of the new action potentials. There will be origination of the new action potentials from here. So that is what? That is after the depolarization. That is what we are getting after the depolarizations. Okay, that's why it is known as, but we are getting early. Okay, before studying the new thing over here, the new cycle. Okay, so that's why we have written it over here, that early after depolarizations. We can get also that delayed after depolarization also in these cases. Now see, delayed after depolarizations, for whatever these mechanisms, for whatever the regions, if we get, for let me say once more over here, that if we get the membrane abnormalities for whatever the regions, for it may be the ischemic injury, it may be the overactions of the catecholamines. In these cases, we will get the fluctuations of the resting membrane potentials. So whenever we are getting the fluctuations in the resting membrane potential, sometimes it can touch the threshold potential. Or whenever it is able to touch the threshold potential, instantly we will see what? Instantly we will get these things will be activated, and it will be, we will get the depolarizations over here, and again in the same things we will get under it. So I mean in this way.